my name is Hannah Weiss, and I will be presenting Inhalational Heroin Use in Leukoencephalopathy, a case report. Heroin-induced leukoencephalopathy is a rare condition with a spectrum of acute and chronic outcomes ranging from mild neurological symptoms to severe neurological deficits and death. Common symptoms include cerebellar ataxia and dysarthria, with generalized motor impairments and altered mental status in more severe cases. To date, only around 200 cases have been reported worldwide. Herein, we report a case of a 20-year-old woman who developed severe neurological damage due to heroin-induced leukoencephalopathy following 1 to 2 years of inhalational heroin use. A 20-year-old woman with a past medical history significant for bipolar disorder, herpes simplex virus, and inhalational heroin use was brought to the emergency department by her father for symptoms including altered mentation, involuntary movements, and ataxia. The patient presented to a different hospital the day prior, but was discharged following unremarkable results on CAT scan, MRI, and a lumbar puncture. She was told to seek a second opinion. 4 days prior to the current emergency department presentation, she developed rapid memory decline and episodes of dysmetria while eating. The symptoms evolved into the inability to walk, decreased attentiveness, speech difficulty, and a mixture of chorioathetotic and hemiballismic movements with dysphagia 3 days after initial symptom development. The patient's last known use of heroin was 1 month prior to emergency department presentation, and the patient was put on Suboxone after that. On physical examination, the patient was found to be alert and oriented to person, place, and time, with the Glasgow Coma Scale score of 15. The patient's vitals were unremarkable, with no fever, an elevated respiratory rate of 26, and mild tachycardia of 105 beats per minute. Her pupils were equal, round, and reactive to light, with both eyes exhibiting abnormal extraocular motion. Her speech was delayed and slurred. Additional physical exam findings included diaphoresis, intermittent agitation, chorea-type movements, diffuse hyperreflexia, tremor, a positive Babinski sign bilaterally, abnormal coordination with dysmetria and an inability to ambulate, spasticity, and bilateral decreased breath sounds. The patient had an EEG taken upon emergency department admission and the EEG showed cerebral dysfunction in the left hemisphere and severe diffuse encephalopathy. A brain MRI was also taken, which showed diffuse severe white matter injury, characteristic of toxic or metabolic leukoencephalopathy. In figures 1 and 2, you can see the brain MRI, which shows confluent symmetric T2 flare signal hyperintensity involving the supratentorial white matter, internal capsules, midbrain, pons, and cerebellar hemispheres. While the MRI was taken, the patient developed symptoms of neuroleptic malignant syndrome, and she was treated in the ICU with 2 liters of oxygen, IV fluids, and vitamins. The patient was initially treated with IV methylprednisone, but this was tapered off after 5 days once no improvement was seen. The patient was intubated on day 4 for acute hypoxic respiratory failure, which required mechanical ventilation. A chest x-ray also showed pulmonary edema, but this resolved on later chest x-rays. The patient was transferred to hospice 17 days after admission. The precise mechanisms and substances underlying neurologic injury due to heroin-induced leukoencephalopathy remain unknown. This case in particular poses challenges in determining pathophysiology due to the atypical symptom progression even a month after cessation of heroin use. This presentation after a month of reported abstinence potentially suggests a cumulative effect of neurotoxic substances intake resulting in progressive damage, though cause of acute damage after first usage have been reported. The mode of heroin use likely plays a role, as well as different routes of administration in the differing rates of leukoencephalopathy, though precise rates are not well described. Early recognition and management are important considerations for patient care.